for waiting. Welcome to the Virginia, Maryland Better Health Cardiac Diabetes Meaningful Use and Value-Based Modifier call. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Virginia Brooks. Virginia, the floor is yours.
Thank you, Erin. Good afternoon, and welcome to today's webinar, Population Health Made Easier. My name is Virginia Brooks, and I'm the Director of Prevention and our Regional Extension Services, VHIT. Thank you for joining us to learn more about our new Quality Improvement Organization program in both Maryland and Virginia. This webinar is being recorded, and a copy of our slides and presentation will be posted on our website next week. All registrants will also receive an email with a link to the recording as well. Now, moving on to our programming. We have a packed agenda today, but I want to remind everyone that all of our webinars are meant to be interactive. Please use the chat function on the right-hand side of your screen to comment or ask questions throughout. And you can see the chat at the top on the right in the blue, and if you click on that, it should pop up and go over to the right-hand side. You can see that Jerry Adler is managing our chat today, and she'll be posting comments, and she'll do her best to respond to you throughout, or we'll get to it at the end. So on today's call, first I'll provide a brief overview of VHQC and explain the new quality improvement structure. Then we'll review the specific projects related to prevention and population health, one for cardiac care, one focused on diabetes, and one on quality reporting and incentive programs. I will explain the goals of each of these projects, the requirements of participating with us, and also the benefits of receiving this no-cost support. We'll close out with a dedicated time for questions and answers. And I'm here with our team of Quality Improvement Advisors, so when we get to questions and answers, I'll let them assist in answering some of your questions. For those of you who are unfamiliar with VHQC, we're a private, nonprofit health quality consulting company. We've been Virginia's Quality Improvement Organization since 1984 and are happy to be Maryland's now as well. We work with different types of healthcare groups, from nursing homes, hospitals, physician practices, home health agencies, and a variety of community organizations and national associations. A number of you may be familiar with us through our Regional Extension Center work, known as Virginia Health Information Technology, or VHIT, where we've successfully helped 3,000 providers in Virginia adopt or implement EHRs and ultimately achieve meaningful use. CMS decided to revamp the QIO for the current scope of work, the 11th. Now, each quality improvement organization is called a Quality Innovation Network, or QIN, because they oversee programs in 2 to 6 states. Additionally, the contract cycle went from the traditional 3 years to 5 years. The map on this slide shows the different networks of states. As noted, VHQC is the QIN for both Maryland and Virginia. We will have quality improvement experts providing technical assistance in your settings in both states. With all of the projects we are discussing today, please keep in mind that we'll be working with you for the next 5 years, which takes us to July 2019. I know that seems daunting, but that is what is necessary in order to truly make an impact. And it is nice to know that you will have a support network in place through a quality improvement effort that is long-lasting. The goals of our Quality Innovation Networks are listed on this slide. First, we have champion local-level results-oriented change, including being data-driven, active engagement of patients and other partners, and proactive, intentional innovation spread that improves and sticks. We want to facilitate learning and action networks so that we provide an all-teach, all-learn environment. We want to teach and advise as technical experts, providing consultation and education and knowledge management so learning is never lost. We want to communicate effectively. Optimal learning, patient activation, and sustained behavior change. All of our networks will feature patients and stakeholder groups in addition to our healthcare providers, so that learning is truly collaborative and we're considering all aspects of the care cycle. The QIMs will focus on improving care access across 3 key aims: better health, better care, and lower costs. Today, we're focusing on better health with our project aimed to reduce disparities and improve health outcomes in cardiac and diabetes patients, and also focus on ways to promote population-based health and preventive measures using health information technology. We're also focusing on lower cost by ensuring providers and hospitals are participating and understand the requirements of PQRS, value modifier, and value-based purchasing. Throughout our work and at the end, our goal is to say that we support a continuously evolving network of dedicated and committed experts in quality improvement, working together in partnership with multiple entities, patients and families to improve health care, support the creation of healthy people and healthy communities, and lower costs through improvement. So now we have our first polling question. I promised you that we would be interactive, so Emily, if you would please make that available. We want to know if you've previously worked with a quality improvement organization, and the choices are just yes or no. And we'll just take a minute to pause so that people can answer. And if for some reason the polling isn't popping up on your screen, you can type your answers into the chat as well. Okay, so we'll just take a second and see if we can see the results.
Just a few more seconds.
Thank you.
Okay, you should see the results.
All right. Yes, thank you. So it looks like we have a mixed audience today. That half have worked with a QIO before and half haven't. So for those of you who are new, welcome. Thank you for joining us and trying to figure out if our services will fit your needs. And those of you who have worked with us or a different QIO, welcome as well. And we look forward to fitting you in into this scope of work and continuing the work that we've done. So now let's get into the details of our project. First, we'll discuss our project regarding promoting effective prevention and treatment of chronic disease, specifically around cardiac health and diabetes, with an emphasis to reduce disparities of care in these conditions. Heart disease and stroke are the first and fourth leading causes of death in the U.S. The risk for heart attacks and strokes are far greater for racial and ethnic populations. Thus, our cardiac work is focused on spreading evidence-based practices to improve cardiovascular health, particularly targeted towards racial and ethnic minorities and dual-eligible Medicaid, Medicare beneficiaries. We will align efforts with the Million Hearts Initiative, which is a joint effort by the Department of Health and Human Services, HHS, and Centers for Disease Prevention and Control, CDC, to prevent 1 million heart attacks and strokes by the year 2017. The initiative focuses on improving the ABCSs: aspirin therapy when appropriate, blood pressure control, cholesterol management, and smoking screening and cessation. A first step in joining our efforts will be to pledge your support to Million Hearts. We're recruiting for participants to join us in this exciting initiative in a variety of settings. We want Medicare-certified home health agencies who will be leaders in the communities they serve. Home health is a perfect setting to assess, educate, and advocate for improving cardiovascular health. Home health teaching supports patient behavior changes and improves outcomes in a comfortable, familiar, safe environment, their home. We will work with participating agencies to utilize a cardiovascular data registry to track progress, emphasize the utilization of health literacy with all educational tools, and provide a forum to collaborate with, share stories, strategies, and successful interventions and activities with others to improve the ADCs for home health patients. We will work with physician practices who wish to improve their clinical quality measures regarding the ADCs, with a special emphasis on hypertension control and tobacco use screening and cessation intervention. We will use PQRS-aligned EHR-based reporting to track these measures. Thus, participants will send us their PQRS measures, which we will analyze and work towards improving their rates. We'll assist with implementing workflows that improve cardiac care and documenting these measures in the EHR. We will also work with patients, family members, advocates, and caregivers in an active way in this work. They'll serve as members in our learning network, sharing opinions on effective patient tools, self-management treatment options, and ensuring we keep the patient perspective as part of this work. If you know anyone who'd be a good fit as a patient member in our networks, please let us know. And that applies to all of the networks that we're going to talk about today. We also plan on making an impact in the communities where we're working. To do so, we'll partner with community and state-level partners conducting similar work to gain efficiencies and scale our efforts. From community partners, we will want to join in and partner on activities such as educational sessions, events like walks or health fairs, and come up with new ideas to provide education about cardiac health. We will also look for speakers and topics for our learning network events. This slide shows some of the benefits you will receive as part of being a member in our cardiac network. As part of working with us, you will receive a flexible, no-cost structure for improvement. We'll be providing technical assistance to improve clinical quality measures and implement best practices into your setting. Additionally, we will have a learning network where you will participate in educational sessions featuring experts and sharing with your peers. You can provide us with suggestions of topics you'd like to hear about, and we'll do our best to accommodate them. We will also connect you to new partners and build relationships between different groups. For example, if you're a primary care provider office, we would like to have a home health agency or community group that is focused on the same efforts in your area so that you know you're transitioning your patient to a different setting with the same emphasis on cardiac quality that you have. We offer a direct connection to CMS and can help you stay in the know with the latest updates. We will also take the data you provide to us, analyze it, and actively work towards improving rates that impact other programs. Now that I've explained the benefits of working with us, it's time to tell you what we are asking of you. If you choose to work with us, we ask that you commit to working with us to implement evidence-based interventions and improve cardiovascular health throughout the scope of our work. For practitioners and home health agencies, we will need data reports quarterly to check on your progress. We also ask that you commit to participating in our learning network by spending time on our monthly education sessions, sharing stories about your success and challenges, and producing action as a result. Ultimately, our work results in better care, so we ask that you keep your patients in mind through this, particularly with education materials. And lastly, we'll want to make sure that we sustain your great work as a result. For our partner organizations, we ask that you support our efforts and open doors to new areas to promote cardiovascular health, including facilitating community-level activity focused on social determinants that may contribute to poor health outcomes. We also ask that just like our provider groups, you commit to participating in our learning network by spending time on our monthly education sessions, sharing successful strategies, or offering other programming that will produce action. The main thing is for all of our participants to want to make a difference in cardiac care. Now that we've talked about our cardiac network, we'll move on to diabetes care. Diabetes is another highly prevalent chronic condition. In the U.S., nearly 13% of adults aged 20 and over have diabetes, and nearly a third of persons 65 years and older have diabetes. Like hypertension, minority groups are more likely to have diabetes as well. Furthermore, diabetes is more common among beneficiaries living in rural counties than those who live in urban areas. regardless of their race or ethnicity. So you can see why this is another area of focus for us. Our goal with diabetes work is to increase adherence to clinical guidelines by participating providers with a focus on key metrics for diabetes, such as H1Cs, lipids, eye exams, and lower extremity amputations. We will assist providers in reporting on these measures for their patients and also work to improve measure rates. Additionally, we want to increase the number of Medicare beneficiaries with diabetes training and will be partnering with organizations to provide the Stanford model of diabetes self-management. As you can see, our diabetes efforts are multi-pronged with an emphasis on provider offices, community partners, providing diabetes self-management education training, and also patients. For our Everyone with Diabetes Counts network, we're recruiting healthcare workers and facilities serving patients with diabetes. This includes physician-provider offices that utilize an EHR, and at least 25% of their diabetes patients are minorities or rural Medicare beneficiaries. FQHCs and rural health centers, stakeholders with established Stanford diabetes self-management programs, or ones who have an interest in creating a program, or agree to refer beneficiaries to diabetes self-management education program classes, certified diabetes educators and community health workers wishing to take part in train-the-trainer programs to teach others about diabetes self-management, Medicare beneficiaries or dual-eligible beneficiaries age 18 and older, especially minority and rural populations with prediabetes, diabetes type 1 or 2, or who agree to participate in a self-management class. Medicare beneficiaries with diabetes who agree to participate in our network activities. So again, we're looking for those patients, families, advocates, and caregivers to join us. And then partner organizations who want to make a difference with diabetes. We also are looking at academic and teaching institutions with nursing, medicine, and pharmacy programs who want to train and certify students in diabetes education curriculum. If you join our diabetes network, you'll receive a number of similar benefits from any of our learning networks, such as peer-to-peer sharing, learning from experts and colleagues, sharing experiences about successful interventions and strategies, building relationships with new organizations and groups that are focused on the same commitment to quality that you are. Additionally, we'll provide quality improvement experts to assist providers with data collection on diabetes measures of their patients. We will provide data analysis on the measures with action plans on how to improve the rates and outcomes and diabetes-related training toolkits and workflow recommendations. We will aid to train diabetes educators and community health workers to increase the number of programs available for diabetes self-management training, and will connect provider groups to these programs so that providers know of quality programs they can refer patients to. Lastly, we'll work with partners to spread the word about diabetes-related services in the community and help support educational opportunities. If you participate in our diabetes program with us, we ask again that you commit to participating in quality work throughout the entire scope of the work. For providers, we will need to collect clinical quality measures related to diabetes on a quarterly basis, so we can measure progress and provide feedback about how to improve rates. We ask that you make time to commit to participating in learning network activities, such as sharing with peers on successful interventions and challenges, and also learn from our experts for training opportunities. Diabetes educators, we ask that you work with us and provider offices to increase the number of persons educated about diabetes and provide patient activation surveys before and after diabetes education. We'll also want you to provide feedback to us so that we can continue to make these programs successful. Community and partner organizations, we ask that you help us spread awareness about diabetes services, specifically by helping to increase the number of diabetes educators and provide venues for diabetes education. We ask that you connect us with patients and advocates to serve as members of our network. So we hope that you all will join us in our efforts to reduce the diabetes epidemic. Now we're going to cover our last new network, our Quality Reporting and Incentive Programs Network. This work focuses on all of our providers and hospitals' favorite topics: electronic health records, meaningful use, PQRS, value modifier, and value-based purchasing. In this network, our goals are to promote the use of certified electronic health record technology functionality for prevention coordination. Basically, this means we want you to use your EHR to manage population health, track immunizations, utilize clinical decision support rules, increase screenings, and reminders for preventive services, track referrals, etc. We also want to engage patients in their care by advocating the use of a patient portal. We'll help providers and patients understand the importance of a portal in sharing ownership of care. We'll guide you around meaningful use and how to achieve it, including core, menu, and clinical quality measures. And lastly, we'll help implement quality improvement interventions for Medicare beneficiaries. For our EHR population health work, we're looking for providers who are most challenged to succeed in meaningful use. This includes primary care providers that are in a small group practice or solo practitioners, ambulatory clinics connected with a public or critical access hospital, community health centers and rural health clinics, and other ambulatory settings that predominantly serve uninsured, underinsured, and medically underserved populations. We're looking for those who want to commit to using their EHR to improve quality for Medicare beneficiaries. And we're also able to help hospitals and critical access hospitals who are or wish to pursue meaningful use. Our network would not be complete without patients, families, members, or advocates to provide input. And we'll work with relevant local partners and stakeholders to ensure we are all working together to make this as easy as possible. An example of a partner organization is the Regional Extension Center, so that we can put our minds together and make sure we're presenting the meaningful use requirements as straightforward as possible. If you participate in our network, you will receive a number of benefits, including a collaborative learning environment with peers and experts. You will receive best practices, lessons learned, resources, and proven strategies to improve your EHR use and achieve meaningful use. These will be convened from other eligible providers and hospitals, experts, and vendors. We will have a peer mentoring program where we can match you with an organization that is similar to yours, but has had success in your trouble areas. We will also hold EHR-specific user groups and other similar small group forums where we can discuss specific documentation or workflow concerns as it comes to your EHR or practice setting. Lastly, we will provide targeted technical assistance, including workflow redesign and data analysis of your meaningful use reports. In order for this to be valuable to you, we're asking that our network participants commit to participating in our monthly learning network activities such as webinars and an online community. We'll need you to share experiences and lessons learned, discuss vendor and workflow issues so that our network can be active. To clarify, anyone from the eligible hospital or provider's office can participate. We're looking for the provider, quality improvement person, clinical supervisor, EHR super user, meaningful use champion, practice administrator, etc. This is the case for any of our networks that involve physician offices. For our stakeholder organizations, we ask that you also participate in our network activities, including discussing hot topic issues and generate ideas and speakers for educational opportunities. Now, I want to touch some on a newer topic, value-based payment modifier. This chart explains the different groups it impacts and when. Value modifier assesses quality of care furnished compared to the cost of that care during a specified performance period. The CMS Pay-for Reporting Program, the Hospital Inpatient Quality Reporting Program, was a precursor to the implementation of the CMS Pay-for-Performance Program. the hospital value-based purchasing program implemented in fiscal year 2013. In a similar fashion, other CMS pay-for-reporting programs involving other healthcare providers such as ASCs, inpatient psychiatric facilities, cancer hospitals, and critical access hospitals are moving towards pay-for-performance programs that reward better value, outcomes, and innovations. So, in 2013, hospitals moved away from pay-for-reporting towards value-based purchasing or pay-for-performance. In 2015, ASCs, psychiatric facilities, critical access hospitals, and cancer hospitals are now moving to value-based purchasing. For physician groups, value modifier is a per-claim adjustment under the Medicare physician fee-for-service that is applied at the group tax identification level and varies by calendar year. CMS is phasing in the value modifier in 2016 based on performance in 2014. Calendar year 2015, CMS will apply the value modifier to groups with 100-plus eligible professionals based on 2013 performance year. For calendar year 2016, CMS will apply the value modifier to groups with 10-plus eligible professionals based on this year, the 2014 performance year. And in calendar year 2017, CMS is required to apply the value modifier to all physicians and groups of physicians starting in 2017. 2016 value modifier does not apply to groups that participate in the shared savings program, Pioneer ACO model, or comprehensive primary care initiative during the 2014 performance period. Our Quality Reporting and Incentive Programs Network will help guide you throughout the transition from fee-for-service to pay-for-performance. For EPs, implementation of the value modifier is based on participation in Physician Quality Reporting System, or PQRS. VHQC will help you decide whether to report PQRS measures as an individual, EP, or group, which reporting methods are available, criteria for earning incentive and avoiding a PQRS payment adjustment. For example, CMS just extended the group reporting action deadline from September 30th to October 3rd. We're able to advise you on whether or not GPRO is the best option for you. Additionally, just a few days ago, CMS made available 2013 Quality and Resource Use Reports, or QRURs. QRURs are available to all groups and physician solo practitioners nationwide who met two criteria. At least one physician billed under the tax ID in 2013, and the 10 had at least one eligible case for at least one of the quality or cost measures included in the QRUR. I know that sounds very confusing, but VHQC will help you access your reports and understand your quality and cost information attributed to your Medicare fee-for-service beneficiaries so you can understand and improve your performance on value modifier. We also will make sure that you know how to access your PQRS feedback reports and what those mean. Those were made available by CMS just a few weeks ago. We'll be combining our monthly network activities with a population health meaningful use EHR group. Participants will receive the benefits from both topics since they are similar. Now, we've come to the end of me explaining all of our new programs, so to celebrate, we're going to have another polling question. We know we have a number of healthcare entities on the line today, and so we're wondering what type of organization do you represent? So Emily, if you would just make that second polling question available, and you'll see once it is made available that the choices are hospital, physician office, home health, diabetes educator, patient family advocate, and community or state organization. So I encourage you to answer that. And I also encourage you to use the chat and maybe take this time, we're not quite to the end, but tell us which program interests you and what you're looking forward to working with us for the next scope of work so that we can go ahead and generate interest. And then looks like polling's over, so we'll just wait a few seconds to see what the results are. Okay, it looks like it's, again, pretty big mix. No patient family advocates, which is really important to us. So I ask that those of you representing other organizations, if you can think of anyone who maybe has hypertension or is a stroke victim or has diabetes or is really interested in accessing their care online from their provider's offices, to let us know, because we really do want to include those groups. So, now we'll hear from Rachel Shortridge, Office Manager with Community Medical Center in Lebanon, Virginia. Rachel worked with VHQC in the past scope of work, and she's going to tell us about her experience. And so, Rachel, I turn the floor over to you.
Thank you, Virginia. Good afternoon, everyone. My name is Rachel Shortridge, and I'm the Office Manager at Community Medical Care in Lebanon, Virginia, which is located in the southwestern part of the state. We have 1 internal medicine physician, 6 nurse practitioners, and 2 physician assistants serving over 20,000 patients in Russell County and the surrounding counties. We have EMDs as our EMR and have been on it for almost 4 years. I first heard about VHQC as the Virginia's QIO when I started working here. VHQC's Regional Extension Center has helped Dr. Yusuf and other providers here reach meaningful use Stage 1, Year 1. The assistance they provided gave us the know-how and the knowledge to successfully attest for Year 2 and now Stage 2 this fall for all of our physicians. We continue to improve on our clinical quality measures with VHQC's help in understanding the workflows driving the measures. We've been an active participant in the VHQC's EHR Learning and Action Network for the past few years. The educational webinars have helped us stay informed with the changing reporting requirements and learn from other practices and experiences. Besides receiving meaningful use assistance, we also received PQRS technical assistance, which made it possible for us to earn an incentive in 2012 and 2013, as well as avoid the payment adjustment. VHQC showed us how to run reports from our EHR to regularly assess our program, and even provided us quarterly dashboards and graphs for our providers to see how they compare to other EPs in the group on select PQRS measures to target for improvement. If we wanted to understand the measure in more detail, VHQC would help us determine if we were not documenting the data correctly in the EHR system. Without VHQC's help, we would not have been able to submit our PQRS data, as they walked us through the entire cumbersome process from registering for an account to uploading patient data to the PQRS portal. I look forward to working with VHQC these next few years on meaningful use, PQRS, and value-based modifier, and I hope that you do too. Thank you.
Thank you, Rachel. Hopefully that gives everyone a good idea of what it's like to work with us and what you gain from the projects that we take part in. So at this time, we're ready to answer your questions. I want to thank everyone for attending today. Erin, if you could please let everyone know how to ask a question, and remember you can also use the chat. So if you have comments related to your experience in this work, please feel free to speak up as well.
The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7.
It doesn't look like at this moment that we've had any questions come in through the chat. So while we're waiting on the line for questions, we can go ahead and post our end of the session evaluation for you to complete. We value your feedback and appreciate you taking the time to give it to us. If you're interested in signing up for us, I'm going to put my contact information on the screen. It's right there. My name is Virginia Brooks again, and you can email me at vbrooks@vhqc.org or call our main phone number at 804-289-5320. We'd love to hear from you, and if you are interested, you can just let us know.
We do have a question on the line from Robert Yokovic. Robert?
Okay.
Hello. Thanks for the presentation. It was great. My question is, we have a kind of unique situation where we're joining up with a hospital from another state that does not belong to this QIN or QIO, and I'm not clear at this point if they're participating in another collaborative. To do two of them in a small hospital our size would be very resource intensive. Is there time that we can wait before we join this collaborative? What is the cutoff before we make a decision on this?
Typically, different projects have different deadlines for recruitment, but we're always open to adding more partners as we go along the way. We're happy to investigate that with you. We're happy to work together with the other entity. Maybe it would be best if we follow up offline to discuss it in more detail if there are certain programs that you're interested in.
Okay, thank you.
Again, if you do have a question, please press the number 7 on your telephone keypad. There appear to be no questions at this time.
Okay. Well, I guess we can go ahead and conclude our program for today. Again, my contact information is on the slides, and I'll put it in the chat as well, just so that you have it in multi-facets. If you're interested in participating, please reach out to me. And if you have any further questions, please reach out to me. Emily, if you would please make a polling available for our evaluation, and if you would take a minute to complete that. And if you're interested in certain things about the networks that you want to see, we are still shaping our work, so we'd love to hear your feedback on that in terms of what would make you excited to join us. We're definitely interested in that as well. So, Erin, I'll check in one last time for some questions.
There are no questions at this time.
Okay, great. Well, thank you, everyone, for your time. I'm sure you'll be happy to have 20 minutes back for your lunch period, and we thank you for joining us and hope that you have a great afternoon.
This does conclude today's teleconference. You may now disconnect.